What's up, future respiratory therapists? In this video, we're breaking down PAV, also known as proportional assist ventilation. Let's dive in. Okay, so here's the problem with PAV. A lot of respiratory therapists don't like it because they simply don't understand it. It doesn't make sense to them, and that's because we are so used to our traditional methods of mechanical ventilation. We go from assist control, maybe SIMV, maybe you're in pressure control, and then we wean down and we finish the mechanical ventilation process in CPAP with pressure support. Okay, and all of those settings and all of those modes make perfect sense to us. But now there's this new mode. And so what is PAV? What is it doing for our patients? How does it work? Let's talk about it. The first thing you know is that this is a Puritan Bennett product. So you'll see it on the 840 or maybe the new 980. Okay, so this is trademarked by Puritan Bennett, and so this is the vent you're going to be using when you use this mode, okay? Now, once you understand that, then you need to understand that this is an open loop form of mechanical ventilation, okay? So open loop. What is open loop versus closed loop? Well, if you've seen any of my other videos, then you know that I've talked a lot about this recently because there's new modes coming out, and most of the new modes, a lot of the new modes coming out are all open loop modes of mechanical ventilation. And it simply means this: open loop forms of mechanical ventilation take feedback from the patient and then do something different. So they're set up with, they're told to operate within these guidelines, but with the feedback you get coming back from the patient, it makes a complete circle from the vent to the patient. This is open loop form of mechanical ventilation. Now, typically, if you are comfortable in assist control, SIMV, AC, pressure control, SIMV, pressure control, it doesn't really matter, those traditional modes of mechanical ventilation, then you know that the vent is told to do something and it does it, but it doesn't care what happens at the patient's side. So for example, if you're in assist control, volume control with a tidal volume of say 500, okay? If lung compliance goes down, the vent doesn't adjust the tidal volume. It keeps giving the tidal volume of 500. It doesn't change that. It doesn't care how high the pressures get. It doesn't even care if you hit the peak inspiratory pressure alarm setting. It will keep giving that volume because it's a closed loop form of mechanical ventilation. Same with SIMV, same with pressure controls and all of those. They don't care, okay? With open loop, such as PRVC, or with VAPs, or with AVAPs, you see where if the tidal volume starts to vary due to compliance or air resistance, the ventilator will adjust, will take that data and then adjust and change what it does on the backside. So if you're in PRVC and the compliance goes down, then obviously your tidal volume is going to start to go down, and the ventilator will say, okay, I'll give more pressure. Okay? Same thing in volume assured pressure support. Tidal volumes go down, the vent says, no worries, I'll give more pressure support. Okay? Those are open loop forms of mechanical ventilation that take the feedback from the patient and do something different. PAV falls into that category. NAVA, good example of this category. It works in response to the patient, okay? So you need to know that it's an open loop form of mechanical ventilation. Whoa, guys, did anybody just catch that mistake? I hope you did, and if you didn't, it's okay, but I'm here to clarify. Okay, let me first explain to you this. One key element of being an educator is being able to recognize when you misspoke. And if you missed it, I just misspoke. I explained open loop versus closed loop mechanical ventilation completely backwards. Okay, and this is where I take a little bit of pride in what I do, and that is that admitting that I'm a fallible individual, I make mistakes, and then I tell you about them so that you can learn from my mistakes. So hopefully you don't make the same mistakes, okay? So let me clarify what I just misspoke on, okay? So I opened up this video talking about the first thing to understand about PAV is that it is what I said, an open loop form of mechanical ventilation. Now that's false, okay? PAV is a closed loop form of mechanical ventilation. So let me clarify real quick what I just made an error on. When we talk about open versus closed loop mechanical ventilation, you have to understand that you have two pieces to the puzzle. This is the vent, this is obviously the patient, okay? This is the vent, this is obviously the patient. Now, an open loop form of mechanical ventilation is one where an input is put into the vent and then it goes to the patient, and then the vent doesn't care what happens on the back side of it. It's an open loop because the loop doesn't close, okay? So this would be things like assist control, SIMV, pressure control, PSV, pressure support ventilation, things like that, okay? You tell the vent what to do, the vent does it. It doesn't care what happens on the patient side of it. It's going to do the next thing over and over and over. It doesn't care the feedback it gets from the patient because it doesn't get any feedback from the patient, okay? Now, closed loop form of mechanical ventilation is when the ventilator, you tell the vent what to do, the vent does it, and then what comes back from the patient dictates what the vent does on the next breath, okay? So we're talking about, things like PRVC, things like VAPS, things like ASV, and what this video is about, things like PAV. Okay, so the vent does what it's supposed to do. The patient responds. The patient says to the vent, obviously it's not consciously, this is subconsciously, tells the vent, hey, this is what happened when you did what you were supposed to do. And the vent says, no worries, I'll make a change and I'll do something different. And this feedback is continual. So the vent automatically adjusts to the patient, okay? So I apologize about my mistake. And it's important for you to understand this because these closed loop modes of mechanical ventilation, which is where the future of mechanical ventilation is going, is important to understand that the vent automatically makes changes in response to the patient, to where with open loop, our traditional modes of mechanical ventilation, the vent does a job. It doesn't care about the feedback from the patient. Okay? Enjoy the rest of the video. Now, the other thing you need to understand is that this mode works off basically the equation of motion, okay? Now, I'm not saying that this is the algorithm that PAV uses. I'm just going to say in general, the equation of motion looks something like this. PMUS equals volume times elastance plus flow times resistance, okay? So basically what this says is that if tidal volume increases or elastance increases or flow increases or resistance increases, then the work of the muscles has to increase to match that. Okay, that's basically what it says. Now, when you put a ventilator on here, you have to add it into this formula. So you have pressure from the vent now plus pressure from the respiratory muscles. When I say the respiratory muscles, of course, I'm talking primarily the diaphragm, but don't forget about the accessory muscles. They play a role in this too. And that has to equal tidal volume times elastance plus flow times resistance. Now, if the word elastance is throwing you off in here, okay, you should be fairly versed in tidal volume, flow, and resistance. But if elastance is throwing you off, like, wait a second, we always talk about compliance. We don't talk about elastance. Well, think about this. Elastance is related to compliance. If compliance goes down, meaning the lungs become stiffer, less responsive to volume, where it requires more pressure to deliver less volume, right? Or more pressure relates in less volume, then the same happens to elastance. Elastance is the opposite of compliance. Compliance is on inspiration, elastance is on exhalation. How compliant are the lungs to receive volume, to receive pressure? And then once exhalation happens, how quick are they to return back to normal state? That's elastance, okay? Now, here it goes. If compliance goes down, say with ARDS, then your elastance goes up. Those lungs become stiffer. They don't want to expand. When they are forced to expand, they recoil back to baseline much quicker than normal lungs with normal compliance and normal elastance. This also helps to explain why COPDers who have a very high compliance have a very low elastance, right? So their lungs, their alveoli become destructed and their distal airways become destructed and they break down and their lungs become basically very big and floppy and very compliant. But then once you fill them with air, they do not recoil like normal lungs do. So they have a very low elastance, opposite of compliance. Very high compliance, low elastance. Low compliance, high elastance. Okay? So I hope that makes sense. And before I move on, let me just throw this out here real quick. Didn't plan on saying this, but a lot of talk about time constants. We know that restrictive lung diseases have smaller time constants, which means there's less time to fill the lungs and also less time to completely empty the lungs. Well, why do you think that is? Well, our restrictive lung diseases, ARDS, pneumonia, just to name a few, they result in a smaller or worsening compliance. Well, because they have a worse compliance, they have a higher elastance, which means they recoil faster, and they need a less time to get all that air out. So you're not worried about air trapping in those patients. But with your COPDers, very high compliance, very low elastance, you're worried about your time constants because you have to give them enough time to get that air out, okay? That has nothing to do with PAV. That's just helping to explain the way this looks right here, okay? So, algorithm built into the software of this ventilator takes all of this into consideration, and it comes up with a work of breathing, and it gives you that in joules per liter. Okay, now joules is a unit of measurement related to energy. So essentially you're talking about how much energy is required to make this part happen. The tidal volume, the flow in regards to elastance and resistance. Okay, so it's given in joules per liter. I think that's where a lot of the confusion comes from with this mode, is because all of a sudden we're talking about mechanical ventilation in joules per liter and we're like, wait a second. Never done that before. We've always talked about centimeters of water pressure, liters per minute, milliliters, liters, things like that. Now we're talking joules per liter. So don't let that confuse you. That's a representative of energy, okay? And they talk about it in work of breathing, okay? Now, let me rephrase this. If your tidal volume goes up or your elastance goes up, which means your compliance is going down, if your resistance goes up or your flow goes up, then all of this must go up. And if this relates to work of breathing, then obviously your work of breathing will be higher with all of these as they increase. Okay? So I hope that makes sense right there. Now, let's talk about how we set PAV. Okay? Because there's really, of course you have your PEEP and your FiO2. But other than that, there's really only one setting that you set, okay? And what you're going to tell the vent to do, I'm actually going to rewrite this back up here. So P vent plus P mus equals tidal volume times elastance plus flow times resistance. So all you're going to do is tell the vent how much percent support to accommodate. So once this formula is figured out and they figure out work of breathing, then what you do is you tell the ventilator, we want you, ventilator, to take care of 30% of the work of breathing, which means that the patient is going to be responsible for the other 70%. So if the vent is doing 30%, then the patient has to do 70%. Okay? Let's flip this. Let's say you tell the vent to accommodate for 70% of the work of breathing. Well, this is obviously going to change, right? This is now going to be where the vent is taking on 70% of this formula, and your patient is responsible for 30%. Now, a lot of people talk about PAV in regards to weaning your patients as an extubation mode, as a weaning mode of mechanical ventilation, okay? I don't think about it like that, but I do know it is highly used, and there's studies out there that show that it is very equal to CPAP with pressure support in regards to successful weaning. So I'm not saying it's wrong to equate it with weaning, but I'm just saying it doesn't have to be a weaning mode. Any patient who is spontaneously breathing can be considered for PAV. Now, that's important because there are no mechanical breaths or mandatory breaths or controlled breaths, whatever terminology you want to use, in this mode. If the patient is breathing spontaneously, this mode is ideal. If the patient is not breathing spontaneously, then you're not even considering PAV, okay? Now, once you have a spontaneously breathing patient, like I said, if you tell the vent to do 70% of the workload, then the vent's going to take on 70% and the patient does 30%. This does not sound like an ideal situation where you would want to extubate this patient because the vent is doing majority of the work, right? The patient is only doing 30% of it. What we find is that when you set it at 30% and these numbers change, patient's now doing 70% and the vent is only doing 30%, that this isn't a reasonable level of evaluation for possible extubation. So you go in and let's say you have one patient on, let's just say CPAP of 5 with pressure support of 5. This would be equivalent to PAV of approximately 30%. But this is also where we start getting confused because as respiratory therapists, we want to know like exactly how much support is my vent giving in terms of pressure applied. See, that's what we don't like about it. At least in my experience. When people talk about it, they go, I just don't like it because I just don't know how much support the ventilator is giving. I realize that it's giving 30%. But that doesn't tell me how much each breath is getting, okay? So we'll talk about that here in just a second, okay? But this is where it basically breaks down to, okay, research has shown that a PAV with a percent support of 30% has very similar outcomes to CPAP 5 with pressure support of 5, even though they're very different modes in themselves, okay? Closed, open loop, it doesn't care what the patient is generating, it's going to give 5 of pressure support. PAV, closed loop form of mechanical ventilation will adjust what this 30% actually means for the patient, okay? Let me draw you a pressure waveform here. So what you'll see when you have a patient in PAV, okay? You'll have a waveform like this. You're going to have about 3 different dots, 3 different breakdowns, okay? So it ends over, and this is in joules per liter. So it ends at 2. So this is what it looks like, okay? And then you're going to have some boxes here. And these boxes look something like this. And this is work of breathing patient. And then you'll have work of breathing total, okay? This is exactly what you're going to see when you're dealing with PAV. If you've never dealt with PAV before, I encourage you to go online, look at some images and stuff, and see what you're going to see. If you've worked with it, then you're familiar with this, and you may have been asking yourself, like, wait a second, this is what do these tell me? Okay, so this zone right here is a green zone. These 2 zones, less than 0.3 or between 0.7 and 1, are yellow zones. And then this, I don't even remember. It's not a red zone. It's just not green or yellow, okay? But ideally, what you're looking for is for your work of breathing on your patient's side to be in this 0.3 to 0.7 zone. And this is a good sign, okay? Now, let's say that, and this is constantly moving. So as elastance changes or resistance changes or tidal volume or flow changes, then work of breathing changes. If the patient starts experiencing an increased work of breathing, this tab right here will increase because it's in joules per liter. Now, if you've told the vent to accommodate for 30%, then the total workload is also going to increase. Okay? This would be a sign of a patient who is not tolerating PAV, a patient who has an increased work of breathing, and 30% work from the ventilator might not be enough for this patient. Okay? Now watch this. If you take this and you increase this work of breathing to, or this percent support up to 50%, and let's say the total work of breathing is now here, and the patient's work of breathing is here at 30%, well, when you increase it to 50%, the total work of breathing is still in this area. But what you will find is that the patient's workload will fall back into more of the acceptable area. So my point is this: when you're watching these two things, you want to see what your patient's work of breathing is. Okay, and you want it to be somewhere between 0.3 and 0.7 joules per liter, ideally. If it gets greater than that, then it's an indication of an increased work of breathing imposed on your patient, and it may be a sign of a patient that is not going to perform well after extubation. Okay? So you got some options here. What do? Would you put them back in the original mode? You can do that. Or you can help that patient by giving the vent more responsibility of the work of breathing. So if you'll just increase the percent support, then now the vent will do 50% of the workload, and the patient will have to do less, and you will see their work of breathing come down, and this gap between work of breathing on the patient and total work of breathing will get further apart. Why is that? Because the vent is doing more and accommodating for more of the work of breathing. The patient is in the green zone, or maybe the yellow, but your total work of breathing is way over here close to 2. It tells you, okay, well, this isn't okay. We don't want to extubate from this, right? If you increase it to 70%, you can get the patient's work of breathing way back here to where they're having to do very little work. But the further apart these two tabs are, patient work of breathing versus total work of breathing, is an indication for you on how much work of breathing is being compensated or made up for by the mechanical ventilator. Okay, so PAV of 30%, total work of breathing and patient work of breathing are going to be relatively close together. As you increase this, then you'll see these two spread apart, and you need to be able to understand that the vent is doing more of the work. The further apart they are, the more work the vent is doing. Let's say you turn this up to 50%, and the patient's work of breathing goes down here to 0.1, which you can't even measure it, but you'll see it down here in the yellow zone on the back side of the 0.3. So in this region here, well, that tells you that the patient is doing hardly anything. You want the patient to be working more than that. So you need to then turn down your percent support, because you need the patient to do more work. You need them to get over here in this 0.3 to 0.7 range in joules per liter, so that they are working their muscles effectively to move towards extubation. You don't want them just free loafing. You don't want them just to be there and like, oh, just let all the vent do the work. Just put them in AC, right? So if you have them in this mode, you want them working appropriately. And that falls between the 0.3 to 0.7 range. I'm not saying you won't ever extubate somebody at the 0.8. 0.8 is in this yellow range here, 100%. I've seen people extubated from there before, but that would be like somebody in a pressure support of 5, CPAP of 5 with a pressure support of 5, and having an RSBI of like 95 or 102. And you go, oh, they're borderline. They look like they're going to do well. Let's give them a shot, right? So understand that the more the patient's work of breathing tab is greater than 0.7, then it's more work that they are doing. All right. Now, let's say you put them in PAV of 30%, and you see your work of, let me start over here. This is getting messy. Your work of breathing tabs come way back here. So this is work of breathing patient, and this is work of breathing total. If on 30% the patient's work of breathing is way over here in the yellow, less than 0.3, that would be equivalent to somebody in pressure support, CPAP 5, pressure support 5, that has a very, very low RSBI. When you look at them 10 minutes into it, you go, oh man, let's extubate them. They look great. They're breathing 10 times a minute, tidal volumes 510. Let's get them extubated. And so that's what that tells you. So 30% means the vent's doing very little, but your patient still has very little work of breathing. Then it means that the patient's respiratory muscles appear to be completely capable of assuming this workload when it comes to work of breathing. Okay? So that's how you use the work of breathing from the patient tab compared to the work of breathing from the total. Total will always be, when you're looking at it, will always be to the right of patient. Okay? Always. Because the vent is doing a percentage of the work of breathing. So the patient can't be doing 120% of the work of breathing and the vent's doing nothing because it's told to do 30%. So it'll always be proportional to total work of breathing, which means total work of breathing tab here, or indicator, whatever you want to call it, will always be to the right of your patient's work of breathing. The closer together they are in the green zone, the better your patient is doing, okay? Now, let's look at it like this. That's kind of how the graphics work on it. Let's talk about this for just a second. If your patient experiences an increased work of breathing, okay, then the ventilator will accommodate also for an increased work of breathing. It will provide more support to that patient. But it still is proportional in the sense that it's still only providing 30% of that increased work of breathing. Okay? Does that make sense? Let's just use some real random numbers here. Okay? If your patient's work of breathing is 10, then that means your patient is doing 7 and your vent's doing 3, right? Well, if this increases to 15, right, then your vent is going to assume more workload, but it's still going to be proportional to the patient. So if we go from 10 to 15, which again, these are just random numbers. These are not anything related to PAV, okay? Just random numbers just so you can see the math. Patient here is doing 10, vent's doing 3. This is 30%. If we look at 30% here, well, you see the vent's going to do 4.5. So the vent increased what it was offering, the support it was offering to the patient. But the patient still has to make up for the other increase. And so it doesn't do it in a sense like, oh, the patient's work of breathing is going up, so I'm going to make up for this work of breathing. No, it's still all very, very proportional. It's only going to assume whatever percentage you tell it to. Okay? So if this was to happen, if the work of breathing was to go up, general numbers, 10 to 15, would the ventilator provide more support? Yes. Will it disproportionately provide more support? Will it make up all of that difference? No. The patient still has to come with more work of breathing on their part because this vent is only going to assume a percentage of the total work of breathing. Okay? So I just want to make that clear before you think like, oh, if the work of breathing goes up, then the vent does more. No, it does do more, but proportionally to the patient also doing more. And vice versa. If the work of breathing goes down, then you'll have the patient's work of breathing will go down, but also the support from the vent will decrease proportionally to what the patient is doing. Okay? One last thing, and I'm going to try to answer the question that I think is most commonly asked on when it comes to PAV, and that is, how do I know how much support my patient is getting? Okay? Well, if you will look at your vent, you will have a tracing. So you probably have a PEEP set, and you will get a rise in pressure when it comes, right? Now, what happens here is this first tracing is this aspect of the formula. And then there's another tracing that follows. And this tracing that follows, that's kind of a bluish color, shaded blue underneath it, is your alveolar pressure that follows this. So obviously, muscle pressure changes first, and then alveolar pressure follows, right? And so that's what you'll see is this tracing like this. That's not the important part of this. What I'm saying is if you're on a PEEP of 5, and you're looking at your vent and you're going, okay, everything looks good. Joe said that if they're in the green zone, then everything is good. But my care team, my physician, my nurse, they're wanting to know how much support is this patient getting. I got an RSBI of 50, and they want to know how much is actually being applied to each breath, okay? How much support? And you say, well, it doesn't work like that because the support is variable in proportion to the patient's workload, to their work of breathing. And they go, yeah, I get that. I know what that says. I get all that, but I want to know how much the patient's actually getting. Well, here's how you know. Look at your peak inspiratory pressure, and if it's 8 and you're starting at 5, then the patient is roughly getting from the ventilator. The ventilator is roughly applying approximately 3 centimeters of water pressure of inspiratory support to do its portion of that 30% PAV, that 30% setting. Okay? You just got to look at your PIP and subtract it from your PEEP, and that'll tell you how much they are getting. Now, it's going to change with each breath. All right? If the patient is kind of breathing kind of all over the place, then you may come back this next breath and get a little higher. It may be 10. Well, on this breath, PEEP of 5, PEEP of 10, then you're approximately 5 centimeters of water pressure of inspiratory pressure support. It doesn't function just like pressure support, but if you want to think about it like that, it's okay. Now, some people are going to get mad if you say that. Oh, PAV is the same as pressure support, except the pressure support is just automatically variable. And they'll say, no, that's VAPS. No, not necessarily. And so it just depends on who you're working with. You know, if they're going to take offense to you calling PAV a variable pressure support mode. But as an educator, I can wrap my brain around and say, I can see how people think that, because the inspiratory pressure will vary based off of the work of breathing. Remember, I told you that if the work of breathing increases, then the vent support will increase proportional to the patient? Well, it will do so by increasing inspiratory support. So the amount of inspiratory pressure assistance that patient gets, or the inspiratory pressure support that patient gets, even though it's not pressure support, will vary. It will increase. If you turn the percentage down and the lungs start getting better and the patient does better, then you'll see these two numbers come closer together. And that means the patient is requiring very little pressure support on the inspiratory phase. Okay? So if you ever want to know how much pressure support, or if you want to equate this to some likings of pressure support, then you just look at your PIP and you subtract your PEEP, and you'll know the relative difference on how much pressure the ventilator applied during that inspiratory phase. Now, this has to be a positive number because our respiratory muscles, our PMUS, these are all negative values. This decreases the breath. This is negative breathing. So the only way we go positive above PEEP is if there is a positive pressure that comes from the ventilator. And you know what it is by subtracting PIP from PEEP. Okay? So that's PAV in a nutshell. Lots of questions on this lately. If you've asked a question about PAV and you happen to see this, please put your thoughts and comments in there because I want to hear them. I want your feedback. I want to know if this video was helpful or not. I want to hear about your experiences with PAV. And if you would, please hit the subscribe button if you haven't already done so. I'd appreciate it. Best wishes.